Can people get inside, please? Get seated. Anyone outside? So we're going to start. Sorry, that's for being a little bit late. We're 10 minutes behind schedule. Nina, are you still there?
Yes, I'm here.
Okay, thank you. Let me introduce you that it's very much an honor to have Nina show up with us today to talk about the ongoing discussion about this pandemic treaty. What are the sticking issues? Nina founded organization called Spark Street Advisors in 2016. She has held the numerous leadership positions, including at USAID, Gavi, UNICEF, and Open Society Foundation. She holds degree from Harvard, Columbia Universities on the faculty of Columbia University Mailman School of Public Health. She's a lifetime member of Council on Foreign Relations, a principal visitor fellow at the United Nations International Institute for Global Health, and a commissioner for the Lancet on Gender and Health. Nina lives in New York City, has written about COVID-19 and the pandemic accord on Lancet Global Health, BMJ, Financial Times, Washington Post, Atlantic Monthly, and Foreign Policy, among many others. So that's actually, she is one of the primary scholars being constantly following this discussion of pandemic treaty. Thank you, Nina. The floor is yours. I will control your slide. You just let me know to go to the next slide or not.
Super, thank you so much. And it's great to be with you today. And I'm sorry I'm not there in person. I would have loved that. And hoping in the discussion section, the camera turns around so I can see some of you in the room. Today, I'm going to talk to you about the state of play of the pandemic accord. Next slide, please, Jinkun. I'm going to go back a little bit in history to sort of what were at least 2 years ago, intertwined, interlocked, interfueled processes. One was a high-level meeting called for at the UN General Assembly in New York, and this is pretty standard practice now for health, that for areas in health or beyond health, that they call for a high-level meeting as part of the General Assembly. And the idea for this high-level meeting, it's funny that I said in health, because they have them for tuberculosis and HIV and universal health coverage and AMR. But the idea behind this one was that it was supposed to be beyond health, because I think what leaders learned through the COVID pandemic is that pandemics are broader than health and engage and involve all sectors, social sectors, education, development, security, trade, you name it. So the idea of having kind of a strong high-level meeting in New York was to give the signal that this is bigger than health. Health is one part of it, but it's not all. Simultaneously, we have the international health regulations, a process that was started in the last century and most recently revised in 2005, which lists out what member states are, very concrete, very detailed obligations during a pandemic health emergency of international concern. And it's things like have a focal point, what you do with the samples. It's a very nuts and bolts, very much health sector focused manual, if you will. It's a treaty, so it's legally binding on member states that haven't opted out of it. So it's a treaty on what states are obliged to do in the context of a FAIC or a FEIC or whatever you want to call it, PHEIC. And then there's the Intergovernmental Negotiating Body. And this was a body set up of member states, that's just another word for the member states, to draft a treaty, a legally binding treaty for pandemic prevention, preparedness, and response. And the concept of why you needed this third thing was the first thing was supposed to give the high-level overview, the high-level imprimatur to say, this is really important and all member states need to pay attention, and we're paying attention to it at the level of heads of state. The second is the nuts and bolts of the health sector. And the third treaty, also legally binding for member states, was supposed to talk about what states do with regard to their obligations to one another. And ideally, it was also supposed to have been greater than health. Let's turn to the next slide. So high-level declaration, not binding, a political process to show we care, we're going to pay attention, and we're going to work together. The IHR, primarily, it's under Article 21 of the WHO Constitution, which is very specific to say about prevention and control of the international spread of disease. And then this new pandemic was to strengthen global collaboration. So as much about what states are doing within their boundaries to how they will agree to work together and collaborate in the face of a pandemic. Next slide, please. So the pandemic agreement process started in November 2020. They put that they would, again, there are two different articles of the Constitution that can result in treaties. Article 21 is very specific to the prevention of disease and spread of disease, and Article 19 is more broadly saying that, and there's something called the Framework Convention on Tobacco, and I'm not sure if you talked about that, but that's also under Article 19. It's a treaty, it's legally binding between states. It requires some sort of ratification that can look different to different states. In some states, such as my own, that would require congressional approval. In other states, it could be presidential or cabinet. So that really depends on the process in the country itself. The concept was to strengthen collaboration and really to have a focus beyond health, whole of society approach. Next slide, please. These are the areas that were foreseen to be covered among many: inclusivity, principles, priorities, and targets, to strengthen capacities, resilience. A big part of this treaty has been equity, and all member states have said they're committed to equity, recognizing the inequities of COVID-19 response. And I think particularly what was seen there as the most egregious was this concept of vaccine hoarding, that rich countries had access to vaccines and poor countries got access to vaccines, diagnostics, and therapeutics much, much later in the equation. There are currently protocols for sharing genetic materials and sequencing. Another big, what was perceived as highly inequitable was when South Africa shared the Omicron variant, and then in the name of science and the genetic details of that, and then had its borders closed. So this was about how could access to genetic samples and data be shared more readily, more easily, more fairly. There is something in place called the Nagoya Protocol, which allows, but that's a bilateral agreement. So states that sign up to it, they agree to share bilaterally. And what this treaty is talking about is an open sharing. So if you sign on to it, there's more open access. And then this idea of One Health, which is that member states need to commit better to really thinking through what Richard Horton and the Commission calls planetary health, or what this calls One Health, is the interaction between animals, humans, and the environment in which they live. So these were kind of supposed to be, in a way, non-negotiables of where the treaty, and I'm going to call it the treaty. It's called the Accord. It is a treaty because it's an internationally legally binding instrument. The word treaty was felt to be not so great. There, as you know, in a lot of countries with strong populist movements, there's kind of an antibody response to the word treaty, but whether it's called an accord or an agreement or a treaty, it's the same thing. It means it's a legally binding instrument. So I may use those words interchangeably. Right now, the word that they're using is pandemic agreement. So these were sort of the non-negotiables of things that we're supposed to see game-changing different text in this new agreement. And one thing that's also crept in, but is not on the slide, is financing as well. This idea that any of these commitments need to come with adequate financing, particularly for LMICs, to commit to surveillance or improving surveillance, that can't be done for free. Next slide, please. So the process of the agreement has been, some call it fast. I don't think it's that fast. I think this is a misnomer on the process, because after the Chernobyl accident, within 6 months, member states signed a treaty on better safety around atomic energy facilities. 6 months took to do that. Chernobyl happened within 6 months. They had a new agreement. So some people say, oh, it's so fast. Well, I don't know. 2 years seems like enough time to do this. So in 2022, they put together a conceptual draft 0, They established these drafting groups to work on the different parts of the text. It's quite a long text. I can't remember if it's 31 articles. It's split into 3 chapters with 31 articles. These drafting groups met, they came up with new texts. And then the idea was that by the end of so-called the intergovernmental negotiating body, the shorthand is the IMB. So I'm going to use that. There have been 9 IMBs, and the most recent IMB 9 was just prolonged. So they're not having an IMB 10 next week. They just are continuing IMB 9. One of the perhaps history will tell us that one of the missteps is what would normally happen in a treaty negotiating process is that you would have a draft. You would have a couple of early drafts. And for those of you that have worked in and with the UN, they love to call these things draft zero, which always makes me laugh because it's like, it's a zero draft, like nobody wants to take any responsibility that it could be a first draft. So they call the thing draft zero. And that means we don't just text on paper. Nobody has any ownership, move along with it. And so at some point, they're supposed to get to what's called a negotiating draft. And the negotiating draft is where they put it up on the screen and member states literally put brackets around the language. They say, I don't want the word independent, or I don't want the word pathogenic, or I don't want this word. And then you put your US says doesn't want the word forever in the language. And that's a negotiating draft. And one of the things that happened, which was a surprise to everyone, is the formal negotiating draft did not appear until the most recent IMB 9. They were all just quote unquote informal drafts, discussion, conceptual drafts. So what that meant is it wasn't until just a few weeks ago that the formal text was on the table for countries to actually negotiate. Now, that has never in history been done in one meeting. And there were a lot of comments on, I think, what the Bureau, which is the group that's supposed to be organizing and coordinating all this, thought was closer to consensus than it was. So where we are right now is that we're in April, and the IMB 9 has been extended actually into May. And what has to happen at the end of IMB 9, or the ideal, is that the member states say, here's the text, we're proposing it to the World Health Assembly, it goes to vote at the World Health Assembly, and it has to be adopted by the World Health Assembly. And that would be the first step in adopting the treaty. And then what happens is member states go back, try to get it ratified in their own country. And as soon as X number of member states have opted in, quote unquote, opted in, or ratified or agreed to it, then the treaty, only then does the treaty go into force. And we can talk more about the details of that. It's quite a set thing. So WHA says, yay, member states go back and ratify or support, minimum number of member states ratify or support, and then the treaty goes into effect through a so-called conference of parties that meets, and then the treaty is in effect for those states that have opted in. Next slide, please. So as I mentioned, this is what the treaty looks like for those of you that have seen it. This was the October version, which was not yet the negotiating version, was just the sort of another draft. And it's split into different chapters. Chapter 1 is sort of principles we agree to, we adhere to, definitions, what's a pandemic, et cetera. There's a lot of cross-reference in the definitions to the IHR. So interestingly, pandemic is not described because it's described in the IHR. And then the third chapter is the governance of the thing. And you'll see here, this is the meat. This is the meat of it, where member states have to agree to all the tricky parts. Research and development, will there be commitments by member states that any government-funded research is open access during a pandemic? So for example, any research that Pfizer had access to because it had received money from the National Institutes of Health, would they or should they have to make that knowledge, know-how, technology, intellectual property available to the broader world because it received public funding? Supply chain and logistics. Many of you have probably heard of the Act-A, which was a mechanism to share drugs, diagnostics, and vaccines during COVID-19. And this is a proposal to set something up more permanently at WHO. Regulatory strengthening so that there's better harmonization, so that if I get my drug or vaccine approved in Zimbabwe, is it also approved in South Africa? Is it also approved in Latin America? So all these sorts of nuts and bolts of how things could work smoother. And you'll note as well how things could move smoother. This is about how things could move smoother among states, between states, rather than necessarily what you need to do in your own country. That's the focus of this treaty versus the IHR. Next slide, please. So we know that while there were a number of states that did support the development of an agreement, consensus at the time to develop an agreement, and many states supported it, we know just in the history of where we are in today's world that not all those states, there have been changes of government, there may be changes in government, that not all those states that supported the development of the treaty will sign on to it at this stage. That's not necessarily a killer deal breaker, because you have forever to sign on to it, and it only needs a minimum number of signatures to enter into force, and that number hasn't yet been decided. Next slide, please. So there are a number of sticky issues that we'll wait and see. The next draft of the agreement is due out on the 18th of April, my birthday, and so I'm hoping that it's a really good draft. But sticky issues are this idea of pathogen access and benefit sharing, and so when a state or a research institute shares a pathogen or a genetic sequence, who gets access to it? Do they have to pay? Do they not have to pay? That system is still very tricky in a way. Sort of how do you avoid the free rider syndrome, and how do you make sure that if LMICs are providing data, that they're getting some benefit back for providing that data, and it's not just going to inform high-income country pharmaceutical companies who make stuff and then don't share it back. R&D conditionalities, that's something I just mentioned. If the Swiss government or the National Institute of Health or the UK government, or really any government, the Rwandan government, funds research and development, how is that to a product that ends up being related to a pandemic, how is that knowledge shared as a public good? This is about public goods, global public goods financing. Who pays? How much do they pay? Where do they pay? There's a new pandemic fund that was set up at the World Bank. There's a proposal within the current treaty that another fund be set up at the WHO, because particularly developing countries are unhappy with the way that the pandemic fund is working at the bank there, and we can go into more detail on what their gripes are around that. But who finances, how to finance, how is financing governed? TRIPS, about whether if countries exercise TRIPS flexibilities, they'll be nailed. There's a lot of fear that if you exercise TRIPS waivers and you go ahead and produce things using other people's intellectual property, that somebody's going to come after you, and particularly where you didn't even know you were infringing on a patent. And there's a big US and EU and other countries are saying this should be dealt with in the WTO, which it wasn't during COVID. They did not reach agreement, and others saying they were unable to reach agreement there, but it's critical to public health, so we need to have some resolution here. Equitable distribution of products. There are some provisions in the current treaty text whereby a certain percent of product should be set aside by high-income countries, particularly any government procuring for low-income countries, and that manufacturers who receive, for example, government contracts should set aside a percentage of product for developing countries and a percentage of product at a low price for developing countries. And then finally on governance, there's some stickiness about where this is governed. Is it governed under the World Health Assembly? Is there a conference of parties that brings that UN General Assembly higher level governance? Because you all know that the World Health Assembly is essentially ministers of health. They're who governs, and there was a feeling, the independent panel that was put together by Tedros himself proposed that pandemics are higher than health. They affect trade, they affect welfare, they affect education. So this can't be just a health thing. So there are all these different blocks of who's negotiating together. There's a so-called group for equity, which I've listed the countries here. There's the Africa group, which aligns often with the group for equity. There's a group of countries that are anti-sanction and that always come together at UN processes, Iran, Syria, who are anti-sanction. There's high-income countries, and I can't remember why I wrote sort of. They don't pretend, they negotiate as a bloc, but they aren't a formal bloc. And then there are countries with manufacturers, and this has also been an interesting thing to watch. So we know that the US and Germany and Norway, we know that there are a number of countries that have strong manufacturing lobbyists, but there are some middle income countries that have that too. Indonesia has a strong manufacturing lobby. India has a strong manufacturing lobby. Bangladesh has a strong manufacturing lobby. Brazil. So there are some cross lines among the negotiating groups. Next, please. So this has actually changed even in the last draft. The original proposal was, so what we've been focused on as a group, and Spark Street is a think tank. We have a small group of researchers who span from the Philippines geographically to Washington, D.C., sort of if you go around the globe that way. And we've done a lot of look at what makes treaties successful. And in the October version, the proposal was for a conference of parties, which would meet regularly. And that means conference of parties, that just means the member states that have signed up to it. A global peer review. So countries would also help each other by doing a voluntary peer review back and forth of their systems, and then state self-reporting. In fact, none of this is in the current text except a conference of parties. And in the current text, there's no provision for any sort of independent monitoring or compliance mechanism, which we think is a grave error and really contradicts all best practice from all treaties to date. So basically, member states are going to sign up even if they get through all those tricky issues, but there's no enforcement mechanism. Full stop. Next slide, please. Next steps, before I just get a little bit to independent monitoring, and then we can open it up for questions and discussion. So on April 5th, from that last draft, the first negotiating draft, which was the March draft, member states put different types of suggestions to the Bureau, which is there's sort of all 6 regions are represented. It's the organizing committee for the thing, and then it's supported by the World Health Assembly, I'm sorry, by a small secretariat at the WHO. They're supposed to, on the 18th, circulate a revised draft. Member states will come back together from the 29th to the 10th. They'll meet in plenary. They'll meet in informal working groups. There was a lot of pushback on the informal working groups, and this was also a problem throughout the negotiations because smaller states. I obviously you can tell from my accent, I'm from the U.S., so I've been watching the U.S. delegation particularly closely, but a delegation like the US or the European Union can bring 12 or 14 to these, and a country, Colombia, has 2 people, or Barbados has 1 person. So it's really sort of unfair in terms of presence in the room. And a number of the smaller states said, we can't deal with all these informal working groups happening at the same time because we're only 1 or 2 people. And then there was the language issue when they were happening in English. So this question of whether or not there should be informal working groups has been also not surprisingly, has been sticky. So they come back on the 29th. By the 3rd, they're supposed to sit in the room and say, hey, we think we're going to get there, or we think we're not going to get there. And if they think they're going to get there, they deal with the remaining tricky issues by the 5th, and they send off a proposal to the World Health Assembly. If they think they're not going to get there, then they have to send something to the World Health Assembly, which says, we're not going to get there, and we give up. We're not going to get there, and we propose continuing this process for longer. There was a lot of pushback to continuing the process and elongating it because particularly the member states and the Africa group said, we just have limited resources in Geneva, and this has been a huge time suck and we're getting nowhere. So why would we spend more time? So there was pretty much, and even some of the larger states were saying, this is a huge time suck. If we don't get anywhere, we should just call it a day, as opposed to continuing this on till the end of time. Next slide. I want to go a little bit into our proposal on compliance. We think the pushback on compliance is unfounded. We looked at over 30 treaties in different areas: chemical weapons, atomic weapons, human rights. And what we mean by compliance is a provision in the treaty that says we're going to do what we said we were going to do, and we're going to report back on it. And one of the things that we heard is, oh, it would be so hard, it would be so difficult to do this, there's no precedent. So we looked at all these different treaties, and we published this longer analysis with UNU and in the British Medical Journal, to say it is possible, it is easy, and it's not that complicated to do, and it won't be that expensive. So please don't push back on it on logistics terms that compliance is hard to do, and there's plenty of great examples from other treaties. Next slide, please. This is the reports I mentioned, which we can share with you on how this could be done better for the compliance. Next slide, please. This is more on some of, one of the things we've also tried to do as a group is just try to make tricky issues, because what we noticed even in the delegations was that you have large delegations and you may have the one health person who doesn't know anything about the pathogen access and benefit sharing system, or the pathogen access and benefit sharing person who's come in who doesn't know anything about governance. So we've tried, as the process has unfolded, to take issues where we hear generalized confusion and just work with other partners to come up with a 2-pager that explains there was a big debate around, should it be under Article 19 or 21? So we wrote a piece on that just to explain to people, we don't really take an issue on those. We just want to explain what's the debate about. Next slide, please. So that's really it on my lecture. Thank you for listening. These are some questions that Button had asked me to approach, but I can stop here and get some feedback or questions from the group, and then we can come back to these as well. So Button, back over to you.
Thank you, Nina. Let's open the floor for questions. Please raise your hand. Nina, there's already some. I think the first question you already answered during your lecture. I think. Please,
Yeah.
if
So
you have any.
If you want me to go through these just quickly, Button, would you prefer me to go through these first?
We have a question in the room now.
Okay.
Good afternoon, and good morning rather, and thank you very much for this interesting presentation. My name is Pernette and I work for the WHO. I really appreciated when you spoke about the inequity in negotiations between different member states. So I used to work for the French Foreign Affairs, and it's true that different teams will be staffed differently in terms of global health diplomacy. Sometimes you'll have technicians coming along and they haven't been taught the rules of engagement. It can go to different extremes. Some of them won't even know that to raise their hand, they have to raise their flag in a certain way. And others will be, veteran in this area. So that was music to my ears. So the first question to you is, what do we do about this and how do we change it? Because when I've spoken internally, I'm off the people who take care of these kind of things at WHO, they say, but it's a member state organization and it's a member state led process. It's for the member states to set up the rules. So unless I'm being very, very cynical, I could imagine that it's to the advantage of certains that the rules are a bit fuzzy. And the other point is the first bullet question that you've got up there on what's the difference between an agreement, a convention, a court, a treaty. And I would add to that, I wonder whether people who use the outputs of WHO know the difference between a guideline and a guidance. For example, it took me a few years working in WHO to know the difference between those two. I think it goes back to the interactions between what the technical teams do and how they serve the member states. So really the question is, what can we as technical teams, technical officers do to progress that so that we're really serving those whom we're supposed to serve? And also, how can the member states address that? Because it doesn't just touch on the pandemic accord treaty, it touches on many, many other negotiation subjects. I work on substandard and falsified medicines. And for many years, counterfeit was a bad word because of manufacturing and generics and all of that. Over. Thank you.
I'm wondering first if you have some thoughts yourselves that you'd like to share or about what you think could be done better.
Okay.
On the spot, or you'd rather I just go for it?
I would suggest something that's very simple, I suppose, but maybe not feasible. It's that the rules of engagement are made clear for everyone, in the sense that there's almost like a glossary of what all the terms mean. It sounds very, very basic, but I think already that would help when people come to the negotiation table and that they understand the processes. And the processes are quite frankly not always very, very clear, but there might be a reason for that.
Yeah, I think you're right on
the question.
There might be a reason.
Question in the room.
Should I go with that one first? There was a lot in that.
Okay, so probably let Nina respond first before we ask the second question.
Yeah, I mean, you asked a lot of different things, all of which we could talk about for hours, and I think they're all really important points. So one of the things that I think one of the things I think a number of people felt that the process was hijacked. There was this whole debate between should it be negotiated in Geneva or should it be negotiated in New York, and the sort of the Geneva crowd was like, this is a health treaty, it should be negotiated here. This is where we talk about health. And the New York people said, this is a treaty and it's about more than health. And this is where we negotiate treaties. And the most successful treaties have actually been negotiated, they would argue, and I could name names of, talked to a number of people who've negotiated treaties who said the most successful treaties are negotiated by treaty negotiators who are informed by technical people, but are professional treaty negotiators and not by technocrats. Not that there's anything, I don't want to use technocrat as a bad, technical experts. I don't want to, technocrat has a bad like vibe to it, but so that was something that a number of people, including members of the high level panel, felt that, and the elders, if you know that group, felt that by nature of having this negotiated in Geneva, it was going to become a technical debate. It was not going to become a political negotiation, which is what it's turned out to, and where it's stuck is as a political negotiation. So that's one thing I think, which I think is really important to consider. And I had not. I mean, I think from my perspective, it turned out to be correct. It's you need professional negotiators. It is a skill. Informed by experts, but the negotiation part is a skill. And you just could see sort of the palpable kind of hatred of people in the room, their anxiety, their dislike of one another, which people that had been in other negotiations said by 2 years of negotiation in a normal negotiating process, you're having dinner together, you're having drinks together, you're mixing your crowd in the lunchroom, you've been through it together, you've had the arc of we disagree, we're doing our positions, we hate each other, we start to like each other, we bend, we fold, and in the end we come to something that we like. That there's a pretty regular arc to treaty negotiations, and this one didn't follow it. And I mean, there was another thing that I think was interesting about this particular negotiation for people, which was the engagement of headquarters, is that many of the negotiators were not empowered to negotiate. And so they had to sort of grandstand every time in the plenary with their capitals listening in, because they had to show the position of their capital. So a lot of that soft negotiation didn't happen because of sort of the Zoom nature of the negotiation of this treaty. The other thing I want to say before we move to a next thing is this. I think Larry Gostin just published a fantastic article that I commend to all of you. It was published this week in PLOS Global Health, and it's about the soft versus the hard power of WHO. And it talks about the hard power is these treaties, which are binding on member states. And the soft power are guidances, guidelines, recommendations, which are adopted by the WHO, but there's no real enforcement teeth around them. And it talked about how, well, WHO was set up to negotiate treaties. It just became easier over time to do these sort of soft things, which in the end have no negotiating power. And so I think we also did a paper on what's the difference between guidelines, guidances, recommendations, Article 21 and Article 19. And I agree that if you're gonna be in Geneva, it's sort of a one-on-one to understand these differences. So that was a long answer, but it's a great question with a ton of important points.
Okay, let's go to the second question.
Hi, I'm Beth Evans. I'm a senior program manager at Gavi. I work primarily on outbreaks, more so cholera than on the COVID team. I really enjoyed your presentation. I appreciated your opinions, I think, that were kind of expressed throughout. And I guess that my main question is around your what you really think will happen in practice. Like there are these ongoing kind of, I guess, stalemate points, delays in the process, but is this just going to sit on a shelf like in some ways some of the IHRs have, or will there actually be more enforcement around it? Should there be another kind of disease X situation? Because I feel like we had the Nagoya protocol, we had other preparedness frameworks and things before. Will this actually be any different as a treaty or as a more binding document?
Thanks, Beth. I think our group believes that without an explicit compliance mechanism built in, it will not. And without regular reporting of whether or not states are complying with their obligations. And the report that we propose is very simple. Is it timely? Is it complete? And is there reason to believe it's not correct? And we use as a counterfactual the IHR. And if you look at the WHO website and the reporting on the IHR, and you look at the reports, I mean, some states forgot to put their name in the top of the report. Is great, or they have some other state named in the top of the report. And Claire Wenham's just written a great article in Lancet 2 weeks ago about how states basically don't comply with the IHR. But the other part that I love on the WHO website is it says, we have complete reporting from all member states. Complete reporting is considered having submitted a report within the last 9 years. And you're like, wait a second. I mean, you work at Gavi. Can you imagine if Gavi was using DPT data from 9 years ago to judge whether or not where countries were vis-a-vis their immunization status? So one of the problems with IHR, which we understand they're putting in place with the reform to the IHR that will be put forward to the World Health Assembly in a couple of weeks, is better compliance monitoring. We haven't seen that language. The IHR discussion has been held incredibly close. There's been very little engagement with civil society or others, but we understand they will be releasing the draft prior to the meetings, which I believe start next week or the week after. I believe it's next week, actually. Maybe it's the week after. So we believe that unless there's an explicit compliance mechanism, again, you work at Gavi, you have a dashboard and countries report every year, and that's a requirement for you to give aid or to give vaccines or give health system strengthening money. In this treaty as currently stands, there's no reporting or compliance mechanism. So we think then it's pretty much useless without that, no matter what they agree. And we think that the IHR, I don't want to say it's useless. You know, I like to speak in hyperbolics because it's slightly more fun when you're lecturing. But member states didn't comply with a lot of the IHR, which was what was wrong with a lot of the IHR, and not the text of the IHR itself. Over.
Appreciate it.
Thank you.
Could we have the references of the articles you've just mentioned, maybe either in Teams or something? I'm trying to search them up online and I can't find them. You mentioned 2 articles.
Yeah.
Thank you.
Yeah,
The articles we shared as pre-reading.
No, I think they're new since then, actually, the 2 that I'm referencing. One came out just on Friday, so I will send them to Button and maybe he can, or I can try to put them in the chat, but I think maybe I'll just share them and afterwards, is that okay if he shares them around?
Yeah. If you share them to Button, we will upload them on the student platform.
Okay, super. One is by Wenham et al. And it was in the Lancet, and the other is by Gostin et al. And it was in PLOS Global Health. But I'll share both of those.
Okay, fantastic, great. Any more questions? No?
If not now, that's Nina. Can you go through the initial questions on the screen?
Sure. I realized my video was off. I don't know if you can see me anyway. Sorry about that. I didn't even know it was off.
Okay.
So what are the changing contexts? Are that making negotiations sticky? For sure. When we were talking to people at the, we did a lot of advocacy before, face-to-face advocacy before the high-level meeting in September. And that was when the sticky big international issue was and is still the Russia invasion of Ukraine. And I would say that diplomats at that time told us that global diplomacy was at an all-time low, and people that were hard and fast diplomats said they'd never seen anything like it. We heard that from all sides. We spoke to 20 or 30 missions in preparation. Fatigue in New York. I think one of the reasons why negotiators in New York were hesitant to take over negotiations or to lead negotiations was because they were generally exhausted and had felt that negotiations, because of, again, the Russian invasion, were to some extent and tensions between the US and China, all sorts of things, were pretty much at a standstill. I mean, October 6th, and imagine that about 1,000 times worse than anybody ever could have imagined. So I don't think that helps. I must say that I was impressed in talking to negotiators, and people were open. The way that it works is as a interested stakeholder, you're not really allowed in the room, and you sit in the WHO cafeteria and you wait until people that you sort of recognize come out, and you kind of attack them. You're a little bit like a bird of prey. But we talked to people from many different missions, and we from missions that, and as maybe me as an American, you would have thought might have been hostile, but they were talking to me as a health person. They said, "Hey, Nina, let's talk about your issue." So we felt that these negotiators were doing their very best to not focus on the current geopolitical context and really to focus on these issues. And the really issue became around equity. And that's where, I mean, I think as quite as, not a cynic, but the interests of the pharmaceutical companies in our business are so great. And this issue about access to pathogen sharing or pricing or commitments around R&D, the pharma lobby is stronger than I ever would have thought. So that leads a bit into the next question. And I think the similar, and I know much less about the Framework Convention on Tobacco Control, and maybe somebody else can do it. I spoke to Gianluca, who has either already lectured you or will be lecturing you, or maybe even is lucky enough to be in the room. He talked about some of the differences. So one similarity is we have big industry excited about both for IHR. Oh, sorry, the IHR. I'm not going to talk so much about the IHR, but the treaty and the tobacco. So we had the tobacco lobby on one hand, very powerful, and here we have the pharmaceutical lobby, very powerful. But the Framework Convention on Tobacco had a genesis well before negotiations began, and that's a big difference as well. There had been a lot of discussion and a lot of push before. So in that way, the negotiation process was much longer, even though the actual kind of formal negotiation process was the same. The precursor, there'd been a lot of work leading up to it. I haven't got a clear answer to the next one. The Paris Agreement, I assume you mean the framework, the climate button. That's what you meant by them. I think what I've noticed is there's a lot of misinformation around this. People will say, oh, in the PIP framework, blah, 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 blah. And you look at the PIP framework and that's not quite it. Or in the Paris Agreement, we don't want to have a conference of parties because like in the Paris Agreement, it's so expensive. And you're like, well, it doesn't have to be. There's nothing in the agreement itself that says it has to happen in Abu Dhabi one year and Tokyo the next and Brazil the third. It could just, there's nothing that says that. So we found that that delegations, because they're not expert in all these different treaty, and that goes back a little bit to, if you'd had it in New York and you had real treaty negotiators, they would be much better able to pull from the relevant parts of all these different other treaties than the health people who are health people and are hearing bits and pieces, but aren't expert in these treaties. The EU proposed the INB. I'm not sure I know enough about those original proposals.
No worries.
If that's relevant. Okay. Lobbying forces, as I talked about, I mean, pharma is big and heavy. Pharma from all around, not just high income country pharma. Pharma is omnipresent and ubiquitous. And it's a big pressure. And you see trade representatives coming into the room from different countries, so not just the health people. So I'm afraid that that big pharma is going to have a lot to do with the outcome of this. And I don't think that's just. I don't think that's just sort of. I think I think you see it. And one of the things that has been interesting is some of the advocates have pointed out that during COVID-19, the US used something called the Defense Production Act, which is essentially compulsory licensing in the US. And there was a provision within the US to be able to use essentially compulsory licenses. And it was used a lot. With indemnification from the government, that if somebody sued you, the U.S. government for infringement of patents in the domestic arena, the U.S. government would would take it on. And there's a similar there was a similar legislation that just went through the EU, but it only applies in the EU, and it's just gone through. And medicines, I can also send a reference on this. What's interesting is it basically says it's okay to do this if it's within the EU, but you can't export. And as soon as you've exported, if you've used this provision, then you've violated patents. So very protectionist. Ellen Tahone writes about that, and I can send you some of her writing on what's going on in the EU around this very same issue.
Okay. Any more questions? I have one question.
Shoot.
Yeah, we'll finish soon.
My name is Shanaz, and I'm just an independent researcher, and I work with education and children for preventative healthcare. My question is, there's been a lot of criticism around this treaty. They haven't done an independent assessment beforehand to know exactly what points need to be addressed with the treaty. In Switzerland, they did do an independent investigation, and that's going to feed what they want to change with the epidemic law here in Switzerland. But was there any independent assessment of the WHO's tackling of the crisis with COVID as a feeding of this treaty, and what points needed to be brought up?
Yeah, that's a great question, and I want to respond to two things. So there have been a couple, and I think that's a big frustration. There was a report done after the Ebola crisis. It's called the Stocking Report, and I think Barbara and the group that did that, it was an independent panel convened by the Secretary General at the time to look at lessons learned from Ebola, and I think people feel Stocking and her group and others feel that those recommendations were completely ignored. And then there was an independent panel that was, I believe it was appointed by Tedros, but it was to look at the COVID-19 response. And it was led by Helen Clark and former Prime Minister of New Zealand, and Ellen Sirleaf Johnson, former president of Liberia, and had a lot of really impressive people on it. And every single one of those recommendations was ignored. So there was plenty of homework done, and they're going to come out with a report in a couple of weeks that basically says just that you ignored all of our recommendations. The other thing you mentioned your work with children. I think personally, I'm quite disappointed that there's absolutely no mention of children in this anywhere. And that speaks to the multi-sectorality of it. We did a lot of work on that preparedness also needs to be social sector, social services, and education. It has to be part of a preparedness plan. That enters nowhere in here. The other UN agencies, and with no disrespect to WHO, but some disrespect to WHO, the other UN agencies were also really shut out of this process. So UNDP, which thinks about conditional cash transfers during emergencies, I mean, all of the other UN agencies, UNICEF, which works on, and UNESCO, which work on children's health and children's education, all of those things are completely ignored. There's not one mention of children in this. And I just don't understand how you could be working on pandemic preparedness and response and not think about what's going to happen with kids' education, for example, or access to basic health services, but particularly for children. So I think that's one that's very disappointing.
Thank you. Any more questions? That if no questions, I know that's a big topic. That's we have no questions. Nina, please share this articles you mentioned, and with me, I will share with all of you in the room. Let's thank Nina for this.
One last thing is we try to do this in real time and people up to date. So you can find that out by following us on Twitter at Nina Schwalbe. I think it's maybe my last slide. If there's one more slide. Yeah, and we just try to keep up to date and everything we hear post. So if you're interested, please feel free to reach out, and happy to talk anytime about the treaty. I'm sorry. Thank you so much, Button, for inviting me.
Yeah, that actually the whole I find you that's through following your tweet, following on Twitter, on X. Oh, I know you are following on this all the negotiations. So please follow Nina on the Twitter. If you want to get the up-to-date information about this IMB discussions. Let's thank Nina for this. Thank you so much.
Bye-bye. Thank you.
Thank you, Harley, for listening also. Okay, we have next speaker. So let me pull up this. This will be the last. So it's my great pleasure to invite Daniel. How to pronounce it? Actually, that's a Daniel. Daniel, that's actually your name, right? Yeah, the Ethiopian name. That's Daniel is currently the unit head of prevention, treatment, and care in the Department of Control of NTD at WHO. Prior to this, he was coordinator of the Innovative and Intensified Disease Management Unit and head of the global, I cannot even pronounce the name of the disease, the control program in the same department, and has worked as a lead for disease prevention control team in WHO Ethiopia and the director of disease surveillance control and health program various level of Ministry of Health system in Ethiopia. He's a physician by training, specialized in tropical medicine and public health, received his Doctor of Medicine degree from Addis Ababa University, master's degree in public health from University of Innsbruck, Austria. Okay, if I pronounce right. Has completed several postgraduate studies in infectious and tropical disease epidemiology, surveillance control, and other public health fields in different universities in Japan, China. Oh, you worked in China, Germany, and the Swiss Tropical Institute. He has contributed over 60 publications and research work at international journals and book chapters and range of different health topics. Of course, include NTDs, HIV, tuberculosis, health system, and reproductive health topics. So a lot of this wide range of different experience and expertise. Thank you for being with us. The floor is yours. Thank you.
Thank you, and good afternoon. I hope you're not tired from the series of long lectures. You're okay, okay. I don't know if this is a PDF version, but yeah. I can give you this one. Ah, okay. Fine, thank you. Okay, my presentation will be on neglected tropical diseases, as we call them. And neglected tropical diseases consists of around 21. Now, with the new addition of NOMA, around 21 diseases, tropical diseases and conditions. As you can see, they are not limited to one etiologic agent, but they can be caused by ectoparasites, bacteria, helminthiasis, protozoa, fungi, and non-communicable diseases like snake bite and venoming is also included among the NTDs list. Next slide. So neglected tropical diseases, they occur in all places. Basically, nowadays, they are also going beyond the tropics. And they are perpetuated by the poverty and the disease cycle. Infection leading to loss of health life, like communicable diseases, and then leading to chronic morbidity, cognitive and growth retardation. This again further leads to loss of education or educational possibilities, and then unrealized potentials. And this leads to poverty, and then poverty is also a risk factor for most of the neglected tropical diseases. So for completing the cycle of poverty. So the intervention of NTD, which I will come in the subsequent slides, will includes preventive chemotherapy, vector control, at disease management, or quality of patient care. Next slide. So these are the major interventions, strategic interventions, 5 NTD strategic interventions. The 2 we call them as medical interventions. The rest are environmental related interventions, preventive chemotherapy and intensive disease management, which includes surveillance, case detection, disability management, and inclusion, are the medical interventions where we have integrated vector control, WASH, health promotion, and also the One Health approach also is applicable for most of the NTDs. So as you can see, NTDs are community-based, but also they are health system dependent. Some of the diseases will come later on, we'll see. They are health facility managed, so they are health facility managed, and they require strong health system. And again, a number of NTDs are zoonotic in nature, and as such, One Health approach is critical for their control, elimination, or eradication. Next. So the preventive chemotherapy approach, it is a community level based diagnosis based on a survey done at community level. And it depends on the use of safe drugs by providing mass treatment to the affected community. And it is considered as a rapid impact intervention because it helps us to curb the transmission within the community and also at the same time curing the infection. These diseases are targeted under this preventive chemotherapy, or sometimes we call it also mass drug administration: lymphatic filariasis, onchocerciasis, schistosomiasis, soil transmitted foodborne dermatoidesis, teniasis, trachoma, and yos. Yeah, next slide. The objective of preventive chemotherapy is through this large scale mass drug administration to to reduce the intensity of infection, thereby controlling morbidity, and also to cure infection for those individuals who are already infected. So this leads to decrease and interruption of transmission. A number of pharmaceutical companies provide donations through WHO for implementation of mass drug administration in several countries around the world. Next slide. The second we call medical pillar is innovative and intensive disease management. These diseases do not have safe medicines for mass drug administration. So it depends on individual case detection, diagnosis, case confirmation, and treatment of the individual cases. So these diseases are dependent on strong surveillance system and ensuring early case detection is critical to prevent either disability or mortality from these diseases. Some of these diseases, like for example, Chagas disease, human African trypanosomiasis, or it's also called sleeping sickness, and visceral leishmaniasis, they can cause disease if not treated early, and they can lead also to chronic complications. So ensuring access to medicine, ensuring access to early diagnostic tools, and intensifying the use of diagnostics and medicine is critical for the control of these diseases. Next slide. So in 2021, WHO developed the second NTD roadmap to control, eliminate, and eradicate diseases. The purpose of the roadmap is twofold. One is to provide for national governments targets, objectives, and guidance, disease-specific and cross-cutting targets in order to control or eliminate these diseases. And the second is to mobilize the international community to provide support to these countries. Next slide. So the roadmap was endorsed by the WHO member state, which we call it World Health Assembly. Definitely, you know that. It was endorsed in 2020 and it was launched in 2021. So it is for the period of 2021 to 2030. So some progress has been made in achieving the roadmap. I will go briefly on the achievements so far in the next slides. So for the implementation of the roadmap, WHO developed around 6 companion documents. The first one is a sustainability framework. This framework is providing actions for countries to implement and to be able to have a sustainable program if donation is not there anymore. The second one is a monitoring and evaluation framework. As the name implies, this helps for countries to do monitoring and evaluation of the progress against the various interventions toward the achievement of the set targets. The third one is rationale for investment. So this is to mobilize international donors, governments, even domestic national governments, to allocate resources for NTDs, building the rationale. What is the return in by investing to NTDs, the economical return? So this makes the case for investing in NTD programs. The fourth one is a strategic framework for integrated control and management of skin-related neglected tropical diseases. Over 50 of the neglected tropical disease, 50% of the neglected tropical diseases, they manifest through various skin manifestation. So the skin being the entry for infection, as well as the skin being the first visible part of our body for making diagnoses. An integrated approach was thought to be implemented for the control of these diseases. And then wash is apparently critical. Most of the NTDs are related to lack of water or inadequate water, inadequate sanitation and hygiene. Therefore, a global strategy in collaboration with the WASH department of WHO has also been developed as a companion document for the NTD roadmap. The last document is One Health. As I said earlier, in order to address the veterinary, human, environmental ecosystem of most of these diseases, a One Health approach is necessary, and the One Health approach guiding this has also been developed as a companion document. Next slide. These are the targets of the NTD roadmap. So as you can see, there are overarching targets. The overarching global targets are related to the Sustainable Development Goal and the WHO Global Program of Work, the 13th Global Program of Work. And then we have the cross-cutting targets, and we have also the disease-specific target, which will come in the next slide. From the overarching target, I think the two key targets are one, the reduction in the number of people requiring intervention. The idea is to bring that to lower than, to reduce it by 90%. And there is a target to reduce the disability adjusted life years by 75%. And we have another one to eliminate at least one neglected tropical disease in 100 countries, and to eradicate two neglected tropical diseases. So currently, globally, as you know, there are 3 diseases targeted for eradication. 2 of the diseases targeted for eradication are the neglected tropical diseases. So these are the disease specific. I'm not going in detail on each of the disease targets, but you have it as a handout. So these are the targets for each of the diseases and with the milestone years. The 2 diseases that are targeted for eradication are guinea worm and yaws. So in this list, in general, summarizing, 2 diseases are targeted for eradication, 8 diseases are targeted for elimination, and the remaining 10 diseases are targeted for control because they cannot be either eliminated or eradicated. Next slide. So progress with regard to these targets, the targets that I just mentioned. The first target is to reduce the number of people requiring intervention. Over 1.5 billion people require NTD interventions globally. So it's a huge number. There is a 25% increase. Now it is around 26, 25% decrease in the period between 2010 to 2021. We have the data for 2022, it's around 26% reduction. The target, as you see, is to reach 90% reduction by 2030. Next slide. The second target is elimination, the reduction of the DALYs, the disability adjusted life years, from 75%. Right now, we don't have the data for 2023 because the DALY, the WHO Statistics Unit, they do the DALYs every 4 or 5 years. The last one was in 2019. We expect the new number or figure this year. But as of 2019, there was only 11% reduction in the DALYs. Next slide. The next one is to eliminate at least one neglected tropical diseases in 100 countries. So we are, I don't know, we are on track, I would say, on this indicator because 50 countries, we have reached the half milestone. 50 countries have achieved elimination of at least one neglected tropical disease. So as you can see in the map, there are countries that have eliminated even up to 4 diseases, but unfortunately they are counted only once because the indicator is elimination of at least one NTD in a country. So this is a list of countries that have achieved and validated by WHO to have eliminated the diseases in bracket this year in 2023. As you can see, 6 countries have achieved elimination for various diseases. Bangladesh for LF and VL is missing in this. Benin for trachoma, Ghana for Gambian Sehat, and Iraq for trachoma, Laos for lymphatic filariasis, and Mali for trachoma. Next slide. On the diseases targeted for eradication, the two diseases, guinea worm or disease or dracunculiasis and Yos disease. Regarding guinea worm diseases, in 2022, only 13 cases were reported. In 2024, also 14 cases reported. So around 14 cases are reported in 2023. So there is a significant progress. Only 4 or 5 countries are remaining endemic. With regard to Yos, around 14 to 15 countries are still endemic. Over 168,000 suspected cases were reported to WHO in 2022. So as you can see, most of the cases of Yos occur in Africa and in the Western Pacific region of WHO. Next slide. Some of the diseases, as you can see, the trend for human African trypanosomiasis or sleeping sickness. This is a disease well on track. This disease is found only in Africa. This is a disease which has been killing hundreds of thousands of people over the past. So this is really a significant achievement in bringing down this disease. Next slide. Another disease, this is also fatal disease, which is called visceral leishmaniasis or Kaladar. As you see the distribution map, there are 3 foci, global hot spots. One is in South Asia, the second hot spot is Eastern Africa, and the third one is Latin America, mainly Brazil. And this disease, we see significant progress of reduction in Asia, whereas in Africa and South America, still the disease is stagnant and causing a significant number of morbidities and mortalities. Another disease is leprosy. There is a significant progress in leprosy, in the elimination of leprosy as a public health problem. Over the past many years, there is a stagnation, as you can see in the period 2013 to 2019, more or less similar number. And in 2021, what do you think is the reason for that reduction of cases? COVID-19, yeah, the COVID-19 pandemic, it has affected most of the NTD programs, leading to disruption and reduced the number of health-seeking behavior, etc. Next slide. So the 3 pillars of the NTD roadmap is, the first one is to accelerate programmatic action. The second one is to intensify the cross-cutting approach. And the third is changing the operating model. In the acceleration of programmatic action, we try to address the technical gaps, the technical tools, be it on diagnostics, treatment, preventive, and control tools. It includes also the service delivery strategy, the capacity building, etc. Next slide. So in this pillar, the 3 major areas of achievement includes the development of normative technical guidance and tools, and several guidance and tools since the development of the roadmap has been developed by WHO. Over 100 publications on guidelines tools have been developed. And also, second one is the global advocacy. The important thing, 30th of January, has been designated as a World NTD Day by the World Health Assembly. So since then, as you can see, different countries illuminating their, monuments. They are celebrating the World NTD Day. The third one, which is relevant if you are interested, is openwho.org, which has several courses on not only on neglected tropical diseases, but on a range of health topics, global health topics. It is free, and they provide also some certificate or credentials attestations. You can enroll and take any of the courses to your interest. So it's called openwho.org. Over 16 million people or students have enrolled on this site taking different courses. The NTD, for NTDs, over 100,000 enrollers around the globe are taking these courses. Next slide. So as you can see, this is the preventive chemotherapy and the number of people who have received or who have been treated for various neglected tropical diseases annually. Again, as you can see, in 2020, there is a drop due to COVID, and from 2021 onwards, it is slowly coming back. We see a slow recovery of the resumption of the intervention and the coverage. So in general, in the period from 2016 to 2019, around on average over 1 billion people were treated for neglected tropical disease. Next slide. This is a coverage for each of the main diseases which are amenable for preventive chemotherapy. Next slide. And this is a number of cases treated for individual case management or individual disease management diseases. Next slide. So on intensifying cross-cutting approach, WHO developed various tools and various strategies. The first one is a preventive chemotherapy. The preventive chemotherapy is implemented in an integrated manner at the community level, bringing together mass drug administration being the platform at community level. Different diseases, they come together and they provide co-delivery of treatments at community level. And the second one is the integrated skin NTD approach. This is a new approach launched last year. And this, through this, we are trying to reach around 10 NTDs, neglected tropical diseases. And it is expected to facilitate the case detection, the early case detection before patients develop late disability and disfigurement. Another is on WASH, and the other is the Global Arbovirus Initiative, as I mentioned, or as you have seen in the first slide. There are different viral diseases like dengue, chikungunya, that are part of the neglected tropical diseases. And there are other viral diseases which are not neglected tropical diseases like yellow fever, Zika, etc. That through a coordination of the Global Arboviral Initiative has been launched to have common front. And we develop common diagnostic, and we develop common treatment for these diseases, and also vector control. Can we do common vector control approach in order to address these diseases? And then the monitoring and evaluation framework, which is really critical, both to establish the actual burden of most of these diseases, as well as to monitor the impact of the interventions against these diseases. Next. So as I said earlier, why integrated control of skin NTDs? As you can see, some of the neglected tropical diseases, it's difficult to differentiate sometimes one from the other. So most of these diseases are also managed or seen by human health professionals like dermatologists. So rather than building a vertical program, it is important to have an integrated program in order to be able, to approach them in a cost-effective manner. And also, there is an overlap. Most of these diseases, they overlap in the same areas. Next slide. So the integration of the interventions can be at different layers of or tiers of the system, or for early detection, it could be at community screening level or individual screening level. Diagnosis also, during the diagnosis, different diagnostic tools are currently being developed for wider screening and wider diagnosis of different conditions and diseases, and also treatment. The treatment aspect, some of them require surgical intervention, some of them require lymphedema management due to lymphedema. Some of these diseases require wound care management. And then the morbidity management, the disability that this disease causes. But at the same time, not only the physical disability, but also the mental health and the stigma. As you know, leprosy has been there since the Bible times, and it's associated with a strong stigma. And it is affecting many people. Cutaneous leishmaniasis also, usually many girls affected by this disease. When this disease occurs on the face, it's difficult in many communities to get married, or some of the women also are subjected to divorce due to the stigma associated to these diseases. The One Health approach is also essential. Significant number of diseases like foodborne dermatogenesis, dog-mediated callous visceral leishmaniasis, dog or other rodents-related cutaneous leishmaniasis, and fish and related foodborne dermatodiasis. All these are require beyond the health collaboration, beyond the health sector, with the animal sector, with the veterinary sector, with the agriculture sector, in order to address this disease. Because for some of the diseases, like rabies, there is a rabies vaccine, but the human health sector cannot provide rabies vaccine. It is the animal health sector. So we need to collaborate through this One Health approach. Next slide. The global vector response, as I said, to address nowadays the viral diseases, especially being pandemic and the potential to be a pandemic. WHO and the world is making more emphasis on these diseases, especially the arbovirus diseases. Right now, there is a huge outbreak of dengue throughout the world, and a large number of people are affected by the diseases. And the Zika epidemic, you know it, and also recently yellow fever epidemic is also re-emerging in several parts of the world. So this is one area of focus, trying to address in a more comprehensive approach. Next slide. Then the relationship of NTDs and universal health coverage. We say NTDs usually occur in remote areas. NTDs occur in a disadvantaged community and in a disadvantaged population, even in developed countries. They occur in disadvantaged population. So there is a need for universal health coverage to address, because universal care coverage, we want everybody to have access to the basic health services. So we in the NTD community, we say NTDs should serve as a litmus paper for the success of universal health coverage. If we continue to see neglected tropical diseases, it means we are not reaching significant number of populations that requires to be reached through basic health services. Next slide. The third pillar is the changing operating models and culture. So as you know, the international health agenda is driven by donors, the international community. Here we are asking countries to take ownership of their health agenda, to take ownership, to take leadership, to be on the driver's seat. But that doesn't come without a cost. These countries should also allocate resources in order to be on the drive seat, in order to drive their agenda. Next slide. So I'm almost coming to the end of my presentation. The main challenges in the implementation of the NTD roadmap agenda is the disruption caused by COVID-19 pandemic. During the outbreak, we were not able to ship medicines to countries. Annually, we ship over 1.5 billion treatments or medicines to countries. We're not able because of the supply related disruptions, as you all know. And that has affected, till now, many countries couldn't resume, couldn't, come back to the pre-COVID era in the interventions. And the funding landscape. Again, COVID did not impact the supply distribution, the case management in the health facilities, the community, but it has also affected the funding landscape for global health. It's not only for NTD, but also for all health programs. As you know, following COVID, the world was in economic crisis, then the war going on everywhere is affecting. So public health is suffering from this changing funding landscape. So this has resulted in slow and uneven progress in many countries. Again, conflict, insecurity, and political instability in many places and countries where these diseases are prevalent is also bringing back the progress or affecting the progress, under perpetuating risk factors like poverty, climate change, and migration and population movement are also another factors affecting the NTDs. Next slide. So outbreaks and pandemics, I have already addressed this. There was 34% decline in NTD treatments. So among WHO was conducting surveys across a range of health services intended for neglected tropical disease were the second most affected after mental health and neurological disorders globally. Next. Another issue is climate change conflict. Over 7 out of the 20 NTDs, more than 7 NTDs are caused by vectors. Climate affects the distribution of vectors. Vector-borne diseases are expanding, and those diseases which were limited are also coming now from tropics to the non-tropic areas. So this can create an increase or loss of the gains with regard to the success of the NTD fight. Next slide. So recovering, it's on the way forward, recovering from the disruptions, filling the remaining normative gaps and addressing the arsenals of medicine. We didn't go in detail, but different NTDs, most of the treatments or the medicines that are currently used for NTDs are old medicines that have been developed for 6-7 years. some of the medicines were not developed even for humans. They were initially developed for animal parasites. Then they were adapted or repurposed for human use. So there is a gap in new treatments, diagnostics, etc. And there is also a need for investment because most of the NTDs are amenable to easily management. They can easily be eliminated, or some of them even can be eradicated. That will definitely contribute to the world well-being as well as economy, and facilitating country ownership and country leadership is also another important thing that we need to do more advocacy for countries to be and to take the leadership. And then finally, as PHC, UHC, health emergency, climate health and other global health initiatives are now the primary lead in financing the global health architecture. The mainstreaming of neglected tropical diseases into this global health agenda is really important in order to have impact on neglected tropical diseases. I think that is my last slide. Thank you.
Thank you, Daniel. Very complicated area. It's impact a lot of people, but in different places. That's also be the nice select entity. This need actions from so many places. It's closely related to poverty. No attention from developed world. No money. No research. No manufacturing of new drugs. No innovation. So a lot of this really challenges that's in this. This WHO has been making efforts all the time by putting the agenda of equity and UHC agenda. So any questions around this?
Hello, my name is Mario. I work at Gavi. Thank you very much for such a great presentation and very insightful. I wanted to ask you for your insights on that last point of streaming NTDs into PHC. And I want to ask you, how do the frameworks to fight NTDs or the roadmap integrates to health systems strengthening efforts or prioritizing PHC versus duplications or inefficiency? Like, what do you think, what do you suggest are the immediate kind of next steps to facilitate that integration? And I'm coming from the fact that Gavi finances health systems strengthening initiatives. And while we are financing the outreach campaigns and we're reaching certain areas only with vaccines, I see a clear missed opportunity to integrate some of the work that you presented into some of the entry points or touch points that we are financing. So I would like to hear from you, what's kind of the recommendation perhaps from WHO and how other partners can promote this?
Thank you. This is a really very interesting question. Definitely, there are a lot of missed opportunities. Being involved in global health and at all levels of the health system, I see that missed opportunities very vividly. Just to tell you a short story. During the pandemic response, as you remember, the whole world raised a huge amount of resource to fight and they put the money for the response in global fund. Huge amount of, I don't know, even the US only was, they put $4 billion, and then number of other countries, the total, exactly, around $4.7 billion. And many countries were not able to fully utilize that money. And they were helping populations which are affected by COVID and there were the same population were also affected by NTDs. There was a lot of possibilities and opportunities to link the community level activities with the NTDs. However, this was not possible, and I was surprised in many countries that we were trying to promote NTDs. The countries could not utilize the money, but they were having short of money for, implementing or supporting few NTD activities. We developed strategies, like for example, the WASH strategy. If you see the WASH strategy, which was important, we were promoting WASH that time. You all remember. The WASH strategy is part of the NTD strategy, and there are also mass drug administrators, community workers who are going from one house to another house, from one community to another community, providing mass drug administration treatments. So these community members can be trained on any additional public health activities, like, for example, Gavi is supporting immunization. Immunization has several outreach programs. And for immunization, again, health education is a core component of any immunization services. These services, a package of services, can be put together for every community, depending on the endemicity of also the diseases, because all NTDs that I show you in the list are not endemic everywhere. So we cannot have a blanket kind of recommendation for all countries. All countries, they don't need to address 21 neglected tropical diseases. Of this, maybe some countries only have 5. Some countries have only maybe 10. Some countries may have only 2 NTDs. So, like for example, even here in Switzerland, we have NTDs. Which NTD do you know is common in Switzerland? Or Spain or Italy? Chagas disease. Chagas disease, because there are a lot of people coming from Latin America, many people, and Chagas disease, it manifests very late, it remains asymptomatic. They get children here with Chagas disease. So if a mother remains untreated, undetected for a long time, they can be a child with Chagas disease. So the most important thing is now for health system strengthening and primary health care for countries, a UHC, PHC menu has been developed. A minimum service, essential service packages. What we are advocating is for countries to include NTD services, a package of NTD services into this health service package. And then for different donors to help them. The problem is with some donors, they say, they put territory and they tell that we will not support these diseases. For example, if I take again Global Fund as an example, Global Fund supports HIV, TB, and malaria. For HIV, visceral leishmaniasis co-infection is one of the co-infections that leads to deaths in HIV infected individuals. But you don't see, or for Chagas also the same, you don't see Global Fund supporting efforts to reduce even the mortality of HIV patients from these comorbidities. So there are a lot of missed opportunities. Right now, we are working very closely with Gavi, supporting the NTDs in the rabies area to help in the stockpiling of vaccines and see how we can promote that. But we really need to work in that area with countries as well as with the donor community. That there is, a win-win kind of gain for the same amount of cost invested.
Thank you very much for the presentation. My name is Janet, and I could like to know more about the third pillar when it mentions to promote ownership. Who should promote the ownership, the donors or the countries themselves? And because I think that it's complicated if a country has no funding, no government funding, no money to sustain the programs, how they can honor any intervention.
Yeah, I think the promotion should be multi-pronged. All the donors, civil society groups, even governments themselves. The reason is nowadays more and more donors are asking for the contribution from the beneficiary countries. They have to show. And in some countries, it's a lack of prioritization. It's for some countries, yes, you are right, it is lack of money or resources. But for some countries, it's lack of prioritization for some of the diseases or for health for that matter. Like there are a number of countries in the list, in the map, if you have noted, who are in the middle class or maybe in the middle class according to the World Bank classification, but they are receiving donation of medicines. I say to those countries whenever I go there, you are in the middle class, the requirement, a fraction of the amount of money that is invested in the big diseases can make a miracle for NTDs, because the medicines for NTDs are donated free of charge. Countries are requested to put just only operational cost to distribute the drugs in the country and in the community to reach the community. So for some countries, it is possible. If they own it, it means they will prioritize it. If they prioritize it, they can put some resources there. For some countries, yeah, you are right. They cannot, we need to support them. We need to continue to support them. If those countries that can support themselves, like for example, India, all those big Ghana, there are several countries, Nigeria, these are, upper middle or middle income countries. They can support themselves. Then the international community can move that money that is going to these countries to support those countries who are unable. So everybody, WHO should do is trying to do its best to advocate to countries, because WHO is convening the member states in the World Health Assembly. But at the same time, donors also have a stake in allocating resources where it is needed, the civic society and the government. Yes. Thank you.
Hi, I'm Pradeep from Nepal. The presentation was wonderful. I just like to take your insight regarding the mental health issue and stigma during the treatment of some entities like leprosy. Most of the community members, they don't want to expose their status and on that issue, how WHO is going to advocate to implement the NTD roadmap. On top of that, another issue is most of the pharmaceutical industry, they are motivated toward the return on investment. And most NTDs, they don't have large profit margin like other medicines. On that condition, most of the countries in domestic manufacturing of NTDs medicine is quite challenging right now. On this context, how WHO recommend or WHO advocate toward the access to medicine on NTD management? Thank you.
Very interesting question. Yeah. So on your first question, you are right. Most of the NTDs are time-old diseases, and there is a strong associated stigma with these diseases. And in some communities, in some countries, there is an improvement, but still, It's really huge. And you if you visit some European countries, you will find the leptosarium. It's very interesting to see how leprosy patients congregated and segregated, and they were put outside of a community, etc. So yes, that is in order to address that, WHO has developed two strategies. One is the integrated skin NTD strategy. We hope this will help, because in the integrated NTD strategy, if a service is provided as an integrated skin NTD, those with venereal diseases, STIs, those with leprosy kind of diseases, they come to skin NTD kind of services. It is not incriminating, so it will help to get many patients to seek services. This is one way. But at the same time, the advocacy that telling the people in the community that leprosy is a curable disease, it can be treated, and those things and programs towards that is also important. So also advocating for removing these practices, laws that inhibit these people. Like, for example, in many countries, if somebody is diagnosed with leprosy, they will just take them out of the country, they deport them. In some countries, there are some laws that do not give these patients to access certain jobs. So this kind of discriminatory laws, etc., WHO is working and monitoring the number of countries that are removing this kind of discriminatory regulations and laws. Yeah. So a number of similar. Then, as you may have seen, one document WHO has developed in TD and mental health and stigma that will help to address that. On regarding your second question on access to, definitely that is challenging. Right now, many pharmas are donating the medicines because, as you said, the market does not have a huge market. That is why WHO is also able to receive the donation. They need it also for their image building, visibility, etc. But for us, okay, we are it's helping to reduce disease burden among the poor community. But in the long run, what we are telling to governments is to develop at regional level kind of pooled funding mechanism. Like in PAHO Latin America, they have a revolving fund. They contribute, they put into the WHO pot. Then WHO help us to do either pooled procurement. So, each country cannot make the minimum requirement quantity required to procure them, even the batch size, because of the low number of medicines required. That's one. The other thing is we are asking, some countries are developing this local manufacturing. So WHO is trying to pre-qualify to provide assistance for improving the quality of the drugs or the diagnostics, and then also facilitating the registration of those if countries opt for local manufacturing of products. We are trying to facilitate knowledge, technical know-how transfer between the pharmas, the big pharmas to the local pharmas.
Was another question?
Thank you very much for this great presentation. So I'm Chiori Kodama. I work for WHO EMLO under the Health Emergencies Program. And actually, I'm the responsible person for high threat pathogen and also all the case management for infectious diseases, including some of the NTDs. And also in EMLO, well, I know that the structure is different from HQ or other regions. And our 22 member states, and more than half of them are FCBs in the fragile and conflict affected and vulnerable countries. And all of those FCB countries are heavily affected by NTDs. And from that reason, actually dengue and chikungunya and rabies, they have moved to health emergencies program since 2019. And ever since then that we are actually witnessing that because those three diseases, when they first moved to health emergencies program, we are kind of surprised to see that there was no clear funding mechanism, you know. So, and we actually felt very bad for NTD program, and also NTD it's neglected for those maybe donors and the high income countries, and also the pharmaceutical companies. But no, it is not neglected for those vulnerable populations. It's a big issue. It's a big issue for those vulnerable population and the community. So we started working on the further integration with the health emergencies program and the financial mechanism. And also, as you know that since last year, when the dengue was a graded 3 emergency announcement, once it was graded as an outbreak and the emergency, that we are quickly able to mobilize resources. So that is our kind of success story for further integration with other programs. And also rabies, it's still the lack of a PEP, the post-exposure prophylaxis. For instance, in Yemen, every year 100 people are dying from the lack of a PEP vaccines. So more the advocacy to the other international communities and also the funders and the donors and the further integration with other programs. Maybe that's something that hand in hand with HQ and at the regional office, we should work on that.
I totally agree. Thank you for bringing this. Definitely, yeah.
And also the concept of outbreak. I'm kind of getting lost, So once, those 3 diseases, once they started moving to health emergencies program, we started calling them as outbreak. And we are quickly able to grab the attention from donors once we started naming them. It's just a matter of labeling.
Yeah, I totally agree. Definitely, yeah, surprising. You are right. I know headquarters also were able to get, the money for resources for diagnostics of dengue, and they were pushing us to facilitate, the product profile development and the pre-qualification of dengue diagnostics, because there are several dengue diagnostics out there. So I totally agree. So we have started discussing with the emergency department, how can we work together? And probably, as you said, for some of the diseases, they may benefit better with that kind of portfolio. I know when cutaneous leishmaniasis was also a major outbreak in Syria, in Afghanistan, etc., in Euro region, the emergency were able to raise a significant amount of resources for stockpiling of the medicines. So, yeah, I think this requires for WHO also to work across departments and also to reach out maybe to donors jointly in order to mobilize, because at the end of the day, it is not the diseases, it is the population which is neglected. Yeah, thank you.
Thank you. So we'll come to the end of the day. Today is a What's a Pack Day. So let's thank Daniel. Thank you so much. So tomorrow we have another pack day. I'm sorry, that's all my fault. I planned too much for that. But more about financing. Tomorrow is how, with all the issues we discussed, how we get those program financed, including the NTD and other things. So how we can get all the things on developed countries' agenda, and global donors and all this kind of community. So tomorrow we expect more discussion around this. So we'll be another room that's already informed. Tomorrow 8:30 we started. So see you tomorrow.
Where we just had coffee, there's a staircase. You walk up the staircase and it's the first classroom there. So that's where we start at 8:30 tomorrow. Okay. Thank you so much for all your questions, and see you tomorrow.
Zoom link with the thing. Okay, send to me because the first must send. You need to. I'm not sure. So say- check already. After morning.
So now we can just stop, I think. I just say end call and stop share. But thank you very, very much for work on this. Fantastic how you.
Yeah, that's a little bit too packed. Next time we find.
And a bit more space for questions, but I have to say, well, we're only for such a long day.
Yeah, we did well. It's a one session for Joseph.
Yeah.
Was like that one.
A little bit.
So we even keep kind of a group discussion. Kind of a group discussion. He prepared well. You
Yeah.
see that he even bit down on all this kind of thing.
Yeah.
Yeah, you see.
Yeah.
And also with the other one that's Jeff.
Definitely. Yeah.
My God.
Was reading. He was a news presenter.
Yeah, yeah. He
Yeah.
was expecting a podium.
Yeah, and then just to stand at the podium. Oh, but it's
By the way, I pitched in Bali.
oh, that's great.
Where are you from? Utrecht. Okay, it's not far.
Not far.
Yeah.
The train is.
And Bali. And
That's a very, very.
yeah, human. I no, the very, I like that because it's I grew up in the movie. I like it. And then
With the
local market,
river.
local market.
Green and the
Yeah,
river.
yeah. Even by the from the
By
dormitory, they can see all the